Hello, my name is Katie Alusma. I'm a DNP student at Palm Beach Atlantic University. Today my case presentation is on heart failure. The patient is BR, a 42-year-old African American male. I feel short of breath in the morning, and he's also here to check his blood pressure. Mr. BR is a 42-year-old African American male, established patient to the clinic that returns today for follow-up on his hypertension and continues to have complaints of shortness of breath in the morning. His BP today is 128/80, and he's currently on amlodipine 10 milligrams PO daily that was initiated his last visit back in April. His blood pressure at that time was 157/87, and the patient was taking lisinopril 10 milligrams PO daily. That was increased to 20 milligrams PO daily during that visit. Patient states his shortness of breath on exertion has improved but remains a factor for him daily. He states he feels shortness of breath in the morning when he wakes up and gradually gets tolerable throughout the day with daily activities. He rates discomfort 3 out of 10 on a scale of 0 to 10. He denies any chest pain that radiates, any feeling of fatigue, or any increased swelling noted in his extremities. His weight is the same as it was the last visit today. He states he sleeps with only one pillow and denies having to wake up in the middle of the night or any difficulty breathing at night. The last echo obtained was back in February of this year. His ejection fraction was below 35%. He's currently taking isoporide mononitrate 60 milligrams PO daily. The patient has been hospitalized once this year for CHF exacerbation back in March, and his last EKG results show sinus arrhythmia with bundle branch block seen in lead 1 and 2, which was obtained back in March. I would also like to note here too, the patient was very non-compliant prior to the last clinic visit, but being that he has realized the medication are here to help him, he's been more compliant, and as you can see, he said that he's feeling a little bit better, but he still has some shortness of breath that he has to deal with. Objective data is as follows, and I also like to note that the diagnoses you will notice for past medical history are diagnosed for this year. The patient was established to this clinic this year. He previously had these diagnoses at a previous clinic, but being that he was not compliant to his plan of care, he doesn't remember dates. So we just started him as a new person, worked him up, and start his diagnoses from this year. Also, if you're questioning about the diagnosis of heart failure, because he was non-compliant in the past, and when he presented to the clinic this year, we worked him up to confirm the diagnosis of him having heart failure in the past. And with his echo, with the ejection fraction less than 35%, and how his initial labs, sorry that I didn't supply that here in this slide, but with those initial results, that is how we know that he does truly have congestive heart failure. So we placed him on the appropriate medication and ordered more labs and, the whole workup for him. The physical exam findings are as follows. His diagnoses are as follows for the chief complaint: I feel short of breath in the morning, acute coronary syndrome, orthopnea, and cardiomyopathy. The plan of care is as follows. We interpreted the labs that were obtained back in April, and abnormal findings were hepatitis C antibody non-reactive, hepatitis B less than 5 liters, and the FiberSure was negative. Pharmacological treatment plan, continue the medication regimen as ordered. Non-pharmacological, encourage patient to maintain heart healthy, low fat, no added salt, low cholesterol, diabetic diet, and to exercise regularly, at least 30 minutes a day for 4 to 5 days out of the week. Encouraged to drink water instead of high sugary content beverages, and note if any weight gain occurs, if his clothes feel clothes or shoes feel any tighter, swelling in arms or legs, restriction of alcohol intake to, instead of the 2, to just take 1 if he needs to drink, smoking cessation continuation, recommendation to sleep on 2 pillows, and to reduce the shortness of breath in the morning. He has a cardiology consult, physical therapy consult for cardiac rehab. He was referred to the public health department to receive a hepatitis B vaccine series and gave information on the importance to adhere to the plan of care. Preventative education, reinforced education on heart failure, education on daily weight monitoring, prevention education on diabetes management because he is pre-diabetic, education on safe sex practices, preventative measures of STDs. He is HSV1 positive. If he does have an outbreak, not to share any of his utensils or his cups or anything like that, to rinse out his mouth with salt gargles. Education provided on recommendation of vaccines due to patient's heart disease, pneumococcal, hepatitis A and B, meningococcal, Haemophilus influenza B, and follow-up plan of care. He's going to follow up with us after the cardiology appointment and return to clinic sooner if needed. Okay, the patient has systolic heart failure. According to the American Heart Association, heart failure with reduced ejection fraction less than or equal to 40% is also referred to as systolic heart failure. Randomized clinical trials have mainly enrolled patients with heart failure with reduced ejection fraction, and it's only in these patients that efficacious therapies have been demonstrated to date. So this diagram shows the different stages of heart failure. Stage A and B are at risk of heart failure, so there's a lot of preventative measures, and their goal is to prevent heart failure symptoms. Stage C and D, the patient has heart failure. Our patient BR has heart failure with reduced ejection fraction, which is in stage C, and the goals are to control symptoms, patient education, prevent hospitalization, prevent mortality. The drugs that are routine use are diuretics for fluid retention, ACE or ARB, beta blockers, and aldosterone agonists. Drugs for selected patients in this group would be hydralazine, isocitabine mononitrate, ACE or ARB, like I said, or digoxin. And in selected patients also within this class, they'll need cardiac rehab therapy or ICD placement or revascularization or vascular surgery if appropriate. Listed below are guidelines for management of heart failure. This was recently updated this year in 2016 from 2013. The only thing that was added was a new drug class, which is ivapradine, which is a current inhibitor, and basically it's indicated to reduce risk of hospitalization for worsening heart failure in patients with stable symptomatic heart failure with ejection fraction equal or less than 35%, who are in sinus rhythm with resting heart rate of greater than or equal to 70 beats per minute, and either are maximally tolerated doses of beta blockers or have contraindications to beta blocker use. But your labs, diagnostic, medications, education, cardiology referral, Mr. BR is up to date with everything. He has a baseline and he gets serial testing every 3 months for his labs. Diagnostic he receives annually, and if he needs PRN. And the medications, he's currently on all the classes. He gets educated on every visit, and now he has a cardiology referral because he's still presenting symptomatic with stage C heart failure despite treatment plan. The research article that I chose on heart failure for this case presentation is titled Patterns and Predictors of Patient and Caregiver Engagement in Heart Failure Care, a multi-level didactic study that was conducted last year, 2015. And it was the reason why I chose this because there was 509 participants for this research study, and it was conducted in Italy. And basically, they have the same issues that we have in America with patients having poor outcomes with heart failure. And not to read everything that's on the slide, but there's 3 levels of archetypes that were found through this study, and majority of the people fell in the class of the second archetype, which is inconsistent and compensatory, with the relations of the caregivers and the patient and the contribution of the plan of care. So basically, in conclusion, from this study, more it needs to be stressed more on the education for the patient, not only for the patient but for the caregiver and for the healthcare provider to be more invested. And if all 3 key players are more vested in the education in the plan of care, the patient is more likely to have better outcomes. And we need to try to strive to get everybody to that expert collaborative level, since we have a vast majority of people with heart failure, being rehospitalized and having these worsening symptoms. There should not be that case. We have so much resources out there. We have so much evidence-based findings that, we need to move forward and make sure that these patients have better outcomes. So the role of the nurse practitioner is to adhere to the guidelines that are set in place by the American Heart Association, the Heart Failure Association. The nurse practitioner needs to collect a comprehensive health history as well as a physical examination, identifying the cardiac and non-cardiac disorders or behaviors that might cause or accelerate the development of progression of heart failure. It's important to know the risk score of the patient to predict outcomes. You want to know volume status and vital signs, weight, JVP, presence of peripheral edema or orthopnea. You want to order the diagnostic tests that are recommended through the guidelines, the labs that we've already discussed, and obtaining them, serial monitoring as needed. Screening for different like hemochromatosis, HIV, rheumatological diseases, amyloidosis, and pheochromocytoma. These illnesses can precipitate heart failure or mimic heart failure. 12-lead EKG, chest X-ray, 2D echo, and then also you can do alternative non-invasive imaging, MRI of the chest, or radionuclide ventriculography. It's important to stress follow-ups and referrals. These patients need to be educated on continuously on the importance of follow-up visits and staying compliant to their treatment plan. Referral to cardiology is recommended depending on patient symptoms and diagnostic findings. As I stated before, everything for heart failure can be managed in a primary care setting unless the symptoms are getting worse with the guideline, with the indicated treatment plans of the guideline. I'd also like to add to this slide another role of the nurse practitioner is prescribing the medication based off what the guidelines recommend. And another note for African American symptomatic patients, it is okay for them to be on a calcium channel blocker with heart failure. If the patient is not African American and asymptomatic, meaning not having any symptoms, calcium channel blockers can actually worsen their heart failure. So you have to look at which stage your patient is, what are the risk factors, what is their ethnic background. You have to look at the whole picture before you just start throwing medication at them, because you can end up precipitating the heart failure and causing it to go downhill. These are the references.